That's the flipped classroom. Go look up your own questions. Let me sleep. Could somebody do me a favor? Could we, I don't want to close the door, but could we just kind of down to like 3 or 4 inches? Because as people are passing by, I'm finding it's probably not bothering you, but I'm really just bothered by the distractions out there in terms of noise and stuff. Apparently, I'm getting ADD in my old age as well as deaf. Well, are y'all ready to dive in? Party? Yes, let's party. So there was a question this morning about question 1 from the practice test. I better put my glasses on. See, I can't read either. So, the setup is the patient's supposed to get 24 million units in 6 divided doses. So what's 6 divided doses mean? What's 6 divided doses mean? How many? Every 4 hours, not 4 times a day. That's an easy mistake to make, particularly in the NCLEX. It's like already you're in trouble. So if it's 6 divided doses, yes, it's every 4 hours, but that's not 4 times a day. And I've seen that is made commonly also in the hospital. People are thinking 4, and all of a sudden it's every 6 hours instead of every 4. Now with the electronic health records, the machine will be yelling at you about, you've got a missed dose, you're late. Okay, so you're going to give 6 doses. So 6 into 24 million is 4 million units per dose. You've got a vial, and this thing about you withdraw 10 mLs from the bag and then replace it. Probably none of you have had this opportunity yet to do, or you have? Want to tell us about the experiment? So here's what I'm going for. That vial is actually evacuated. It's under negative pressure. So when you draw up that 10 mLs and punch the syringe into the vial, it'll suck it right in. It's not like you're having to work against the pressure because you're trying to put 10 mLs into a vial that already doesn't have room for it. And you mix it up and then you draw it back out and replace it. So now what you have is 20 million units in. No, that's not right. We don't want to do that. All right. Let me read this question a little more closely. Yes. See, that's what's missing in those instructions. Yeah, and so it's like already we're giving way too much medication, right? If you follow these directions exactly, you're going to give 20 million units in that dose instead of 4. Right. Okay, good catch. Because as I read it, I thought, this does not make sense to me. And I read it last week and said, yeah, it looks good. I don't see any problems. So clearly, I was having a moment. Okay, so, you can do the quick math, right, on what are you going to program the pump to for milliliters per hour? To give that 50 over 30 minutes? 100 an hour, right. So that part's easy. And what's the final concentration if you do, as was suggested, which is to put 2 mLs back into the 40s? So you now have. Then you add the other 8 of saline. That would make sense. So you have 50 mLs with 4 million units in it. So what's the actual concentration per ml? 0.08, yeah, or 0.8. 0.8. There's an 8 in there. Don't answer it that way on the NCLEX. It may not do. So you were asking about the last part of the question, right? Well, just tell me what your question actually was. Does it make more sense? Because you didn't know that you were only supposed to put 2 mLs back. So you caught the same confusion that I did. Okay. All right. Okay. No, not alt Bob. Let's talk briefly about that extra credit thing that apparently most, if not all of you did. In general, really good job. I appreciated seeing your thinking and the way you were putting things together. The only thing that I would challenge is most of you, and it was hard to hear and it was a little indistinct, didn't get that he was actively in withdrawal. So to me, the primary priorities, first was monitor his, heart function, because that'll kill him like right now. The second was monitor his withdrawal, because that will trigger heart problems and kill him right now. I mean, alcohol, ETOH, ethanol is potentially a fatal withdrawal, yeah. Yeah, well, does withdrawal last 3 weeks with active hallucinations? I don't think so. And he's talking about having recently, if not like then, the nurses are discussing the fact that he's hallucinating, or has been very recently. My guess would be this guy has been actively drinking, ran out of money, so unintentionally, he started withdrawing. And that probably triggered the PSVT. I mean, the alcohol alone could trigger it in the first place, and withdrawal could also trigger it. Because he's going to be dehydrated, his electrolytes are deranged, and both of those situations are not good. And the atria and, the carotid sinuses are very sensitive to your hydration level. So if you have a tendency to go into AFib and PSVT, dehydration can trigger it. And certainly, potassium and calcium being wacko, which they will be, could also contribute to that. Any other questions on that? I mean, overall, you guys wrote good answers. I was pleased. You're thinking like nurses. Oh, what's today? And as I said in my little email, I'm sorry, I'm still I'm working like, believe it, I've been putting in 12-hour days trying to get this stuff all up to date. Yeah. Well, okay. Have any of you had a patient on the CIWA protocol, CIWA? A couple of you, okay. Somebody want to look that up? I can never remember what the acronym actually stands for. The last two letters, WA, is withdrawal from alcohol. It's like an institute that came up with this. So on the CIWA protocol, which he is going to be on if he's admitted to the hospital, you are checking their vitals like every 4 hours. And there's a list of about 25 questions or items that you do in that assessment. You're going to be looking at their vital signs, and then you're going to be asking them. And it's interesting, you ask alcoholics while they're in withdrawal. They're not honest about their drinking because they're embarrassed about it, so they'll tell you they drink about half of what they actually drink. But if you say, are you hallucinating? Are you seeing things that aren't really there? They'll answer you honestly about that. Do you have stuff on your skin? Are you hearing things? So those hallucinations are part of the protocol, and they get a score for that. If their anxiety levels are up, or if they're agitated, they get a score for that. So you add all these things up, you get a score at the bottom, and it says, if you're above this number, give Ativan and the dose. And you'll notice in the video, they ordered a banana bag and Ativan. He was actively in withdrawal. You wouldn't do that if he wasn't in withdrawal. It just wouldn't make sense. What's in a banana bag? Anybody know? A lot of electrolytes, as well as, all kinds of, because they're, metabolically, nutritionally, they're really depleted, and these are all things that are very bad, and the body doesn't like it. Any other questions about the little exercise? You first. Because he was what? He was an event. He was breathing on his own. That might have been a different video. You're remembering. Yeah. For the withdrawal. Yeah. And nobody actually mentioned the other reason they gave him Versed aside from sedation. You want to go for it? Well, what's the reason you use Versed in potentially really uncomfortable procedures like retrograde amnesia? Exactly. You don't want them to remember what it was like to have that upper GI endoscopy or the colonoscopy. Yeah. Well, they would have taken him down to the point where he might have awakened for a moment and gone right back to sleep. And by the time he finally did awake, he wouldn't remember really anything other than, I came into the ED. And then you start asking really dumb questions because you're a little loopy. Okay. More questions, or more questions? He was a little confused. It was irritating, and he was trying to pull it off, and his hands were, withdrawal. Well, when you're dealing with somebody that is that weird, you might consider it, he does that all the time. That's, they asked me last year if I wanted to post these videos through Marin's public TV. And I said, well, that would be really cool, except a lot of times I talk about stuff, and I can see where the public would think we're pretty, cavalier about stuff. Death, dying, people, including, weird alcoholic withdrawal patients. So we're not going to do that because I don't really want to make nurses look like we're unsympathetic. Because we are sympathetic, most of us, except for those that are burned out. God, it's already 12 after. I better get rolling here. So we're going to take just a really quick review of, we talked about IV calculations last week, didn't we? And we talked about, when you're running the big bags or a banana bag, you're doing this. You're doing replacement, replenishment, managing fluid levels and electrolytes. When you're running Ativan, that's a whole different story. We're not replacing anything. We're doing sedation. So we talked about this, right? Isotonic, hypotonic, hypertonic. You know how to calculate. Are there questions about calculating flow rates and stuff with? Are there questions about how to do weight-based dosing with your IV pump? Okay. Y'all remember how to do flow rate calculations using your drip factor? It's in the ED. You've hung a bag. You don't have a pump. What are the things to remember? Somebody tell me what's really important about that drip factor. This is a question that's too easy. You have to know it. You have the whole thing with algebra. You've got 3 variables. You can't solve it if you have 2 unknowns. So you have to know, what the concentration is and what the drip factor is, and then you can figure out what your flow rate's going to be. But basically, you're going to count, if it's a micro drip tubing, which you might use in neonates or pediatrics, or in the ICU or ED if you have somebody who's on like amiodarone or a drug that is really active, cardioactive, you're going to use a microdrip because it's 60 drops for 1 ml. So you can pretty finely tune how much they're getting. Normal drip, normal tubing is somewhere, anywhere between 10 and 20. Frequently, it's 15 or 20 drops per ml. I've seen it as big a drop where it's 5 drops per ml. Anyway, you have to read the package. You have to know that. If you don't know that, you don't know Jack, as the saying goes. Any questions about your pumps, programming the pumps, knowing what you need to know? Because I think you're taking a little quiz on MedMath soon today. Just like the Med-Surg 2 students who are all like, oh my God, we can only miss one. Yeah. Does Dr. Harris require 100% or 90? Okay. Well, that's because you're seniors. You're supposed to know it all. Okay. Okay. You're almost nurses. Yeah, okay, great. You don't get that RN, and what it stands for is real nurse. So there will be notes published sometime real soon now to go with this little lecture here. So last night I was just, actually what I negotiated with Dr. Harris was my goal is to keep everything as close as possible. When she's talking about dysrhythmias, I want to be talking about antidysrhythmics, drugs that, so that you have something to carry forward, and we're both talking about the same drugs. So we have 2 strips that are profoundly dysrhythmic, well, one in particular. And then here's the normal sinus rhythm as a 12 lead, okay? So that's what this lecture is about. Can anybody identify the top one? What's that called? What did you call it? Yeah, PVCs. And the way you would chart this if you're in the ICU is like he's having runs of PVCs of 2 or 3. 3 or 4. He's having 3 and 4 beat runs. And the frequency with which they're occurring is part of your concern in the ICU. If it's, once an hour or so, it's like, well, okay, we're aware of that. If it's every couple of minutes he's having runs like this, it's much more concerning because it looks like he or she is heading down a path that might be leading to this. What's the one? Yeah, VTAC. There's also within your ACLS protocol, they will call that a tombstone rhythm. Not only because it looks like a tombstone, but he's soon going to die because you can't maintain that for very long. They are getting circulation still, but it's a deranged rhythm and likely to degenerate into VFib or asystole. So we'll talk about these. Okay, atrial flutter. Have any of you seen a strip with flutter? They can be very distinctive. Now this one just has, we've got 2 and 2 and 5 and 2 and 2. They may be that way. Sometimes they're very regular. And atrial flutter is a little different than AFib in that you will find that often it is a regular rhythm in terms of the QRS complexes. And what you will see is like every third P wave, you have a QRS complex. So the way you chart this is they're in atrial flutter 3-to-1 if they have 3 P waves for every QRS. If they have 2, it's 2-to-1. If they have 4, it's 4-to-1. And if it's like this, well, then you would just say atrial flutter and it's variable. But, his circulation probably isn't too compromised. The atria are actually working. They're actually, helping, supercharge the ventricles, and the ventricles are getting blood. So other than him saying or her saying, I'm having palpitations, because it does feel that way, have any of you ever had a little skipped beat or a palpitation? You felt it was like, what was that? That was different. You probably had a little PVC or a PA. What's a PAC? Premature atrial contraction. Yeah, there's both. Good. Go. You want me to go back up? Now, you will find that they use a lot of the same meds kind of across the board. You're going to see beta blockers and calcium channel blockers showing up on several of these slides. Those kinds of drugs. So what does a beta blocker act on? What site? Did I hear beta? Yeah, they block the beta site. How many beta sites are there what kind of beta receptors are there in the heart? Are they beta 1 or beta 2? Yeah, because you all remember there's only one heart, right? Beta 2s are in the lungs. You have 2 lungs, 1 heart, most of us, unless you're the doctor. Any of you watch Doctor Who? Nah, okay. I'm a geek. Right, what? Okay, so the beta blocker sits on that site. And so the drug, the normal neuro impulses that would tell the heart to beat faster can't get through. Because if the site that tells the heart muscle to contract more rapidly because it's being stimulated by that neurotransmitter, it's being blocked. It's like putting the key in the door. Can you put a second key in? So what happens with a beta blocker is it fits the lock, but it doesn't trigger the stimulus that makes the heart beat faster. So it controls the rate of the heart by impeding, the communication on the vagal stimulus. I think it's a vagal nerve that stimulates that. You've been running and it makes your heart beat faster. That's information getting to the beta 1 site, and a beta blocker impairs that. Talk louder. Yeah. So when you're giving. Why is metoprolol a parameterized drug? What else does it drop? So what do the orders usually say? Anybody remember? Have you seen these? Like if you're in the cardiac unit? Yeah, it'll say hold for heart rate less than 60 and blood pressure less than, systolic less than 100. So that's why you want to actually know the vitals before you not only walk in the room, before you go to the Pyxis. Why pull a drug that you're not going to give? If their heart rate's 58, you wasted time and energy and stuff like that. So a little bit of the whole thing about time management. Besides, you want to know those numbers. If you have a patient that is unstable enough that you're giving these kinds of drugs, you want to have at least dropped in, said hi, made sure they're alive, that they're making sense, and, you know, often if you're working in the critical care, you're taking your own vitals. There's no aides in critical care. You do your own. You take your vitals, you go to the med room, and you get what you get. AFib. So when you look at this, how is this different from the previous slide? Yeah, there's no P waves. It's really just jello jiggling, and that's kind of what the atria are doing. So they are no longer effectively pumping. What do the atria contribute in terms of cardiac output? When you go into AFib, what's the drop-off for that person? How much less are they pumping in general? Anybody want to make a random guess? Yeah, it's not quite that high. 25%. Now, if they're like me, I have my moments of PSVT. I'm aware of it, but I've had it enough that I'm not like, oh. But if it's new onset for somebody that's never been in AFib before, they're like, oh, wow, I'm dizzy, I'm tired, I have no energy, I kind of hurt, I don't feel good. Anyway. So now we got PSVT, which is what our guy on the usher credit was in. He actually there was the N in there, which something I don't remember. But the point is, when you look at this rhythm, it tends to be so fast you can't really figure out what's going on. What you're aware of is it's a narrow QRS. That's important because it means it's not V-tach, but it's some kind of a supraventricular tachycardia. And the P, what's paroxysmal stand for? What's a paroxysm? Basically, it means it's semi-random and they go through bouts of it. It just sort of comes on, bzz, they go into PSVT, and they may or may not, I can stop mine with, carotid massage. Actually, just carotid pressure. Don't do this if you haven't had a carotid ultrasound, and never do it on a patient, because you have to be a doctor to do it or yourself. But if you have plaques and you do this, you could throw, it could rupture the plaque and you could have a stroke, and that's even worse than the PSVT. Again, now you saw the adenosine. Did I put up the other one? There were 3 videos I wanted to put up. I think I only remembered to put like one of them up there, which was this guy going through the whole procedure because it was usher credit. Did you see the one? I think it was done like maybe in India, because there was nothing about, is it okay with you? I mean, they just did it. Patient had a heart rate of like 200. Gave her adenosine. I think it was her. It should be, but I may not have remembered to put it up there. If I didn't, I will. She has about a 5-second pause. Yeah, there should be 3. I'll get the others up there today. Well, no, tomorrow. But adenosine will pause. Typically, it's not at all unusual for them to have a long pause. That was a really long. It was like 5 seconds. So, do you think she was conscious during those 5 seconds when her heart stopped? And then they wake up. Yeah, because it interferes with the conduction. Well, depends on the kind of rapid heart rate you've got. So, in some cases, it will treat. In other cases, it stops it, slows it down enough that they can see what the real rhythm is, and then it picks right back up. So it's used in both. It's used to diagnose as well as to treat. If it treats it, you're done. If it doesn't treat it, it's like we got other things to do to figure out what's going on. And again, calcium channel blockers, beta blockers. Does this look familiar? PVCs. A single PVC, it's like, okay, fine. Who cares? Well, it's not quite that cavalier, but we all have random PVCs. Pretty much everybody. If it just happens to be at a bad moment, you're that unfortunate basketball player for the high school or college team, and then you go down. And this is often treated with lidocaine is actually not used all that often anymore. It has other side effects people don't like, and it's cheap. They don't get any money out of it. Amiodarone, and of course, again, beta and calcium channel blockers. We'll talk about amiodarone in a minute here. VTAC. So there's two kinds, really. This one, the one above, where it's intermittent, is called non-sustained. It just means it's occasional. Again, like I said, if you're following this patient and those occasional non-sustained events are happening every 3 or 4 minutes, you're calling the doctor. If it's a couple times an hour or 3 times a shift, you note it, and that's it. You're going to pass that on a report. Anybody know what time it is? Because I don't have any clocks here at the moment. 8:28. So I've got 20 minutes. Okay, good. Sustained. Like I said, ACLS, you'll see this, and they'll call it a tombstone rhythm. Again, lidocaine, amiodarone, and then I'm not going to dive into it today, but I actually did put up on Moodle the ACLS protocols. You would be well advised to review those, especially before your little simulation day, because we'll be talking about that stuff. But the ACLS protocols tell you what to start with, what to follow with, what the frequency is, and how many times it can be given. It's really, they're brief, they're very interesting reading, and they are related to the specific rhythm that you're treating, whether it's asystole or VFib. Do you shock asystole? Yeah, no, you don't. Why? There's nothing to shock. There's no electrical activity. For a shock to work, there has to be some kind of electrical activity. So if they're in VFib, it's fibrillating. It means that there's at least, chemicals there, the heart's working, just it's confused. And you can shock it to say, hey, wake up, and, everybody work together. But if it's just a flat line, they're dead. Yes, you're doing CPR. So like as you're going through, are we all together here? Thank you. So with, if somebody is in asystole, or for that matter in VFib, you're always doing CPR until the situation changes to the point where you aren't. The idea of CPR is that you're going to be able to circulate oxygen and the drugs to get the heart to the point where it will at least go into VFib so you can shock it. That's the hope. Yes, it is. And then they discovered, by the way, if you put it directly into the bloodstream, here's what happens to the heart. People doctors make these discoveries, probably because they were doing, an injection and they hit a vein, didn't catch it, and the guy went, ooh, oh, your heart stopped. Okay, good. Well, maybe not good. Torsades de pointes. If I was a French-speaking person, I'd know actually how to say that. Any of you study French? Nobody? Okay. She won't admit to it. Okay. All right. So you can see it's this interesting slinky-looking pattern, and it rapidly deteriorates into VFib. It's a fatal rhythm. So if you see this on the NCLEX, identify it as a fatal rhythm, please. That would be a good answer. And meds, ACLS protocol. Meds. VFib. So there's this coarse VFib and fine VFib. It doesn't really matter what kind of VFib it is. It's VFib. They're dead or dying or will be dead soon. When I used to do my ACLS class in the hospital at Kaiser, our instructors opened the class with, when you're working with a dead person, because that's what they are. You are resuscitating them. If you don't do anything, they're not walking out of there. So that's the deal. And, if you keep that in mind, it sometimes helps to know that, in essence, you're working with somebody who's really not there. And the painful and uncomfortable things you're doing to them, they will only know after the fact in the terms that their chest is sore because they got shocked or you broke a rib or cracked a rib. And if you had the opportunity to do compressions yet on a real person, what was it like? How big were they? Was it a big person or a small person? So were you doing like the 2-inch compressions? Was it hard? It wasn't tiring? Oh, so you were rotating through. Do you think if you had been all by yourself? Okay. It's actually, yes. You'll find by the third or fourth rotation, the sweat's running down your face and you're doing... Did they lower the bed as far as possible? Were you tall enough with the bed lowered as far as possible to be at a comfortable working height? Okay. Do you know, what else could they have done to get you to a safe and comfortable working height? Step stool. We have them in the hospital. They're like this tall. And, if you're not, but if you're 4'1", you're not going to effectively do compressions from the side. Reminds me, this is one of those stories that, we can't publish on TV. When I was going through my program, we were in the ICU at Oakland Kaiser and talking with one of the nurses, and she was about like this big. We had a patient who was, he was over 400 pounds. And so when she would, he was sedated, luckily, and vetted and all this stuff. I don't remember what she was doing, but she was standing on a step stool. She lost her balance and fell onto the patient. And because of his large size, basically it was like being on a waterbed. And she was having to call for help because she couldn't get off the patient. She's like, help me, I'm drowning. No. Okay. Classification of antidysrhythmic drugs. Actually, on the NCLEX, you may be finding questions that talk to you about the class of the drug and what they're used for. This would be a good thing to review, like in general, Is it a class 1A, 1B, or 1C? I used to know this stuff. I don't anymore, actually. To be perfectly honest, it's no longer, I don't work with it actively. So these are the kinds of things that when you're not doing it every day, they kind of go away. Or you get into like beta blockers or phenytoin. What's phenytoin? Up there with lidocaine. What's that other drug? You've all probably given it. No? You never had a seizure patient? No? Nobody's had to give Dilantin? Okay. Oh, I'm hearing the occasional, oh yeah, that's right, I did give that. Okay. So Dilantin is also used for, it's a sodium channel blocker. That's a faster channel than the calcium channel. Amiodarone. So amiodarone increases the action potential duration. What does that mean? It stretches things out. One of the side effects that you need to be aware of with amiodarone is that QT prolongation. In other words, the time from the start of the QRS to the time of the T wave can stretch out. Now, what's the risk with that? Anybody remember? We were talking about it earlier. As that T wave stretches further and further away from the QRS, what's the risk? Fatal dysrhythmia? Yeah, what triggers it? What causes it? And what triggers the torsade? Well, it's the QRS. It's the R on T, otherwise known as Ron T, which was our instructor in ACLS. This is named after me. So R wave is on the T wave, and it depends on where it hits on the T wave. You guys remember refractory versus non-refractory? What those words mean? Like if they have a refractory pain, what is that? What are they telling you? Refractory means it does not respond. So if their pain is refractory to the pain medications, it means no matter what you're giving them, they're still at 10 out of 10, or maybe 12 out of 10, or that's what they're going to tell you. What is one of the refractory? Somebody has abdominal pain that's refractory to pain medications. What might you want to be thinking about? How about a retroperitoneal bleed? So if they're bleeding behind the peritoneum, no matter what you give them for pain, it really is ineffective. So that's a hint that you've got a retroperitoneal bleed. Anyway, refractory means it doesn't respond. So in that T wave, the first half or so, if you hit it with an R wave, it is refractory to that impulse. It won't respond. It's okay. In the last half, third, if you hit it with that R wave impulse, it might respond, but in a disorganized fashion, which can trigger the torsades. So it depends. Now you're really playing Russian roulette when you start having R waves on the T wave, because you could trigger the torsades. Calcium channel blockers, DILT or diltiazem, and verapamil. My mom used to take verapamil when she would have her AFib episodes. And of course, there's DIG and adenosine, which we haven't really talked about DIG very much. And you can see there's a nice little thing. It increases or may increase or decrease. What is one of the primary concerning side effects of antidysrhythmic drugs? Somebody raise a hand, please. Yeah, exactly. They can cause what you're trying to treat. That is the most common, most concerning side effects. Very well. Good job. Dysrhythmia. Okay. Here's all your adverse effects. There's a lot of them there, aren't there? So like with that, amiodarone, you're looking at pulmonary toxicity, thyroid disorders, bradycardia, hypotension, SA node dysfunction, AV block, ataxia, QT prolongation, torsades, vomiting, constipation, It's kind of like, it's like watching TV and they're advertising this wonderful drug and it's going to make your life, just really great. And at the bottom, they've got a list that long of all the potential complications, including you could die taking this. Do you guys ever read those little, it's fast, they don't put it up very long and it's pretty fine. But I look at that stuff and I'm just like, oh, geez. I actually know what all those things are saying and the general public doesn't. To me, it's just deceptive. But they want to make their money. Okay, I'm being disrespectful. Oh, my God. 8:40, so we got 10 minutes. Questions about this good stuff, which I may or may not be able to answer.
Do you want us to focus on basically any of the drugs that you talked about in here? Or do you want us to learn more like, calcium channel blockers in general have...
So here's what I would recommend. Let's go back to this one, I think. I would kind of learn the drugs sort of the way they're presented here, in terms of, you notice the calcium channel blockers and beta blockers are treated as a class because they all have these characteristics. Yeah, dilantin's really not used very often in cardiac situations. Lidocaine may be. It's actually not a first choice drug, although some cardiologists think it should be. Quinidine. I would really, if you learn about amiodarone, beta blockers, calcium channel blockers, DIG specifically, no adenosine, you're probably going to be pretty well prepared. Those are the drugs that I remember consistently being used in the ICU, cardiovascular ICU, ED. My experience in the ED when I had my first bout of supraventricular tachycardia, was adenosine, which didn't really work, followed by diltiazem, which also didn't really work. They sent me down to do a echocardiogram, and I converted while I was in there, which was nice because then I didn't have to go through the cardioversion that guy did. They were going to shock me. I was very glad that they didn't have to. Particularly after seeing these videos, like, oh, that wouldn't be any fun at all. I was proposing I'd ride my motorcycle home afterwards. Like, yeah, idiot. So, did that help answer your question about what you should be thinking about? Those are the drugs you see kind of used all the time. At least now it can change from hospital to hospital. Sometimes they have favorite drugs. Sometimes they don't. Sometimes they're experimenting without asking permission. Doctors get to do that. Can the doctor write pretty much any order he or she wants? Almost. Yeah, they have a very powerful position. Hopefully they actually know what they're doing when they do that. Other questions? Yeah. Oh, good. We got lots of questions. We'll go. Oh, yes. Thanks for reminding me. Did you guys argue amongst yourselves and come up with a plan? Do you want one or two? You want one? Okay, let's do this. You guys need to do like an internal poll and also with the other group, and send me a group answer because it needs to, it needs to be the same for both. You can argue about this outside of class. Do it on your Facebook page. Come to a conclusion on your Facebook group and send that conclusion to me. How's that? Yeah. Okay. I need to hear the question. Thank you. Mm-hmm. If they're compensatory, it means that that you're getting sufficient blood flow, basically. Go for it. I like your answer. Continue. Were you answering the question on compensatory versus? Go ahead. So it does impact circulation and cardiac output. But you're explaining it better than I would have. Thank you. Good question. Excellent question. I don't know if that's part of pharmacology, but it's a good question anyway. Okay. Any other questions? Yeah. Yeah. I just have to write it first. I'll be posting this as well. And I'll be posting the audio too. So, yeah. My goal is to make life at least a little easier for you all. I know that it's hard. Well, it worked. The feedback I got last semester was not only, I can look at the statistics on YouTube and see if people are looking at stuff. And people were looking at stuff, especially before the exams. So, if it seems to be a useful tool, and not that everybody really wants to listen to a lecture twice, but the advantage is, of course, you can fast forward to parts. I mean, the only thing you can't do is raise your hand because I'm not there. But then you send me an email. Bob, I didn't get that part in the lecture when you said blah, blah, blah. I'll see if I can answer it, like what's compensatory versus non-compensatory. Any other questions? Yeah. Oh, good. Oh, I love this. You guys are actually asking questions. Last year you're like... Of course, you were the morning class. I know. Okay. I'll get you in a second. The syllabus is definitely under construction. Do not take anything past a day as correct, because it's not. So reading assignments and everything are wacko. They will get fixed. Probably tomorrow. Uh-huh. Know what they are. Why do you want to know what the side effects are? So you can identify them. And what else can you do? You can teach a patient. If you're experiencing this, it's expected. If you're experiencing that, call the doctor. Some side effects are concerning and perhaps threatening, and others are like, yeah, it's really uncomfortable. Sorry, but you still need to take the med. But you can be a more effective teacher if you know what the side effects are and if there is anything to do about them. If you go lie down for a half hour, you'll feel better. Go take a jog. No, that's probably not a good one with cardiac drugs. But, know the side effects in general as to what they do. And actually a better resource, because this doesn't have it, but your IV drug books and stuff like that, usually they will list the side effects in terms of, percentage of what percentage of the population will experience this. So you can see, does this happen to like everybody, or it's like, 0.1%, it's rare, but it happens. Not that necessarily helps the patient, but it can be good for you to know. At least I think it could. Technically, I think we're done. But you're welcome to stay for the rest of the day if you like. Oh, that's right. Your next class is in here. Mine's up in the library again. Excellent. And, like I said, you all did a good job on your little extra credit thing. I got to figure out how to score it, but well done. I appreciate what you're doing.